In this video, we will explore real-world scenarios highlighting the common challenges and pitfalls of managing anticoagulations in inpatient settings. Let's dive in. A 65-year-old gentleman who was diagnosed with STEMI at a remote hospital that lacked angiogram capabilities. The patient was given thrombolytics and transferred to our facility for cardiology services and coronary angiogram. During morning sign-out, the daytime physician asked if the patient was started on anticoagulation, but the nighttime physician said no because the patient was just given thrombolytics 3 hours ago. The patient is scheduled soon for coronary angiogram. Now, my comment on this: anticoagulation should be started immediately when administering thrombolytics therapy to a patient with STEMI. We give both at the same time. The same applies to PE patients with hemodynamic instability. This is different from using thrombolytics in ischemic stroke. In ischemic stroke, the American Heart Association and the American Stroke Association guidelines recommend delaying initiation of anticoagulation for 24 hours after thrombolytic therapy, with the concern, of course, to minimize the risk of hemorrhagic stroke. So this patient should have been started on anticoagulation at the same time thrombolytic therapy was given. Before moving to the next scenario, if you would like to receive a summary of this video and access the previous video summaries, kindly subscribe to my Substack page. The link is provided below. A 68-year-old lady with paroxysmal atrial fibrillation and Apixaban presented with shortness of breath and was found to have a large right-sided pleural effusion. Right-sided thoracentesis is anticipated. How do we manage her anticoagulation here? Now, right-sided thoracentesis, paracentesis, central line placement including PICC lines, diagnostic endoscopies with or without biopsy, dental procedures, minor dermatological procedures, ophthalmological procedures, ICD placement, pacemaker placement, all considered minor procedures and regarded low risk for bleeding. Now, the American College of Chest Physicians guidelines support the continuation of anticoagulants for minor procedures due to their low bleeding risks. The same applies to antiplatelets. But that's what the guidelines. In real-world settings, unless the procedure is emergent, I highly recommend checking with the performing physicians to see if we should hold anticoagulants or not, to avoid any unnecessary delays. Unfortunately, not everyone goes with these guidelines for different reasons. If the performing provider wants to hold oral anticoagulants, we hold direct oral anticoagulant for 48 hours and hold warfarin until the INR falls to a level that's deemed safe by the performing physician, which is typically equal or less than 1.5. Bridging with unfractionated heparin or low molecular weight heparin is warranted in patients who are taking warfarin and have a high risk for thromboembolic disease, such as mechanical heart valves, atrial fibrillation patients with recent stroke or TIA, recent DVT or PE, and patients with known hypercoagulable status. Bridging is initiated when the INR falls below the therapeutic range, typically less than 2. And remember, bridging is not warranted for direct oral anticoagulant given their short half-lives and rapid onset and offsets, unless the therapy interruption is going beyond 48 hours. Low molecular weight heparin is preferred over unfractionated heparin in bridging, giving its more predictable anticoagulation effect, and should be stopped 24 hours before the procedure. If unfractionated heparin is used instead, it should be stopped 4 to 6 hours before the procedure. Oral anticoagulants should be resumed after the procedure, and I always ask the performing physicians if it is safe to resume them or not. Direct oral anticoagulant can be simply resumed. The same for warfarin if bridging was not warranted. If the bridging was warranted, then we continue the bridging until the INR is therapeutic. Let's move to a new scenario. General surgery consulted you about a 65-year-old male post-op day 1 after elective colectomy for colon cancer. Currently, the patient is NPO due to post-op ileus. He has a history of paroxysmal atrial fibrillation on rivaroxaban, which was held 2 days preoperatively. Surgery approves resuming anticoagulation. What's your next step? Since the patient is cleared to resume anticoagulation but remains strictly NPO, the options are unfractionated heparin or low molecular weight heparin, and I prefer low molecular weight heparin, as you said, due to predictable anticoagulant effect, unless there is contraindication or high bleeding risk, in which case unfractionated heparin may be a better choice. And actually, it's a better choice. In post-op day 3, the patient had a bowel movement, advanced to a clear liquid diet, and you decided now to transition from enoxaparin back to rivaroxaban. Here is the strategy that we follow. To transition from unfractionated heparin, start direct oral anticoagulant at the time of heparin drip discontinuation. From low molecular weight heparin, start the direct oral anticoagulant when the next low molecular weight heparin dose is due. There is no loading dose is needed when resuming direct oral anticoagulant. Simply restart the home dose. Let's move to the next scenario. A 62-year-old man on hemodialysis was admitted with severe pneumonia and acute hypoxic respiratory failure. He was started on antibiotics, steroids, and unfractionated heparin for DVT prophylaxis. On hospital day 5, the intern noted a platelet count of 60,000 down from a stable range of 140 to 150,000 over the previous 4 days. The intern, of course, was concerned about the possibility of heparin-induced thrombocytopenia. What would be your next step? Now, heparin-induced thrombocytopenia is a serious condition with significant morbidity and mortality if untreated. And one should not wait for thrombosis to develop before suspecting HET because thrombocytopenia often precedes thrombosis. Calculating the 4T score is the first step when suspecting HET. This score is a clinical tool used to estimate the probability of heparin-induced thrombocytopenia. It evaluates 4 parameters related to HET and stratifies patients into low, intermediate, or high probability categories. This scoring system helps guide further diagnostic testing and management. You do not need to memorize it. Just use one of the free online calculators. If the 4T score is a low probability, we generally do not pursue HET antibody testing or presumptive treatment for HET. We do not also discontinue heparin or start a non-heparin anticoagulant. If the 4T score is an intermediate or high probability, we make a presumptive diagnosis of HET pending results of antibody testing. Let's calculate the 4T score for this patient, and I use the Med Calculation app, which is free online. We start with thrombocytopenia, so our patient platelets drop from 140, 150 to 60, so more than 50%, and the platelet nadir was above 20, so it gets 2 points. The timing of platelet count fall, clearly in our patient was on day 5, so there's a clear onset from day 5 to day 10, so it gets 2 points. Thrombosis none, 0 points. And other causes for thrombocytopenia, it's possible because our patient is on antibiotics, was septic. So these are common causes of thrombocytopenia. So the result is 14%, which is intermediate probability for heparin-induced thrombocytopenia. So our patient score was intermediate probability for HET. The next step is to immediately discontinue all sources of heparin and administration of a non-heparin anticoagulant, unless of course there is a bleeding or a high risk for bleeding. Now, most at this stage stop all heparin resources but do not administer non-heparin anticoagulants despite the absence of any contraindication to use that. Heparin cessation alone is not sufficient in HET since patients with HET remains at risk for subsequent thrombosis. So if you decide to test for heparin-induced thrombocytopenia, you must act pending test results. Testing for HET starts with screening antigen assays like ELISA to detect antibodies against platelets factor 4. These assays are fast and highly sensitive but have moderate specificity, leading to potential overdiagnosis. A negative result will rule out HET, but if positive, we send a confirmatory functional assays. Unless the clinical suspicion is high, then no need. You just continue the treatment. Non-heparin anticoagulants include argatroban, bivalirudin, fondaparinux, or direct oral anticoagulant. Remember that the use of fondaparinux and direct oral anticoagulant in HET is considered off-label. Argatroban and bivalirudin have a short duration of actions and are good choices for critically ill patients or with those at high risk of bleeding. Argatroban is safe in renal insufficiency, while bivalirudin is good in liver dysfunction. Fondaparinux is good and easier to use option, but contraindicated in patients weighing less than 50 kilo, in those with creatinine clearance less than 30 ml per minute, and it's also best avoided if the platelet count is still less than 50,000. Now, my favorite direct oral anticoagulant agents are best used in stable patients. They are equally effective, and remember, Apixaban is the direct oral anticoagulant of choice in renal insufficiencies and dialysis patients. Now, back to our patients. He was feeling much better on day 4 without any active bleeding. So we sent the screening ELISA test and started him on the loading dose of Apixaban 10 mg PO/BID times 7 days. The screening test returned positive, prompting us to proceed with a confirmatory functional serotonin release assay, which a few days later confirmed the diagnosis of heparin-induced thrombocytopenia in our patient. We added heparin to his allergy list and discharged him on oral Apixaban 10 mg PO/BID to finish a total of 7 days, then 5 mg PO/BID afterward. The duration of anticoagulation therapy in patients with heparin-induced thrombocytopenia should be at least 4 weeks for isolated HET and 3 months for HET with thrombosis. In the case of using argatroban and bivalirudin, have your pharmacist help with the protocol and monitoring, and transition to oral anticoagulant once the patient is stable, preferably direct oral anticoagulant. If you decide to transition into warfarin, we must overlap until the INR is therapeutic for at least 24 hours. Let's move to the fifth scenario. A patient with mechanical mitral valve on warfarin presented after sustaining a fall and was diagnosed with a subdural hematoma. His INR was 2.6, neurosurgery scheduled or evaluated the patient and planned an emergent surgical evacuation. They recommended also immediate reversal of anticoagulation effect. What's the optimal strategy here? As you know, warfarin is still the drug of choice in mechanical valves, AFib with moderate to severe mitral stenosis, antiphospholipid syndrome, or when you cannot afford other anticoagulants, and sometimes if you do not want to use Apixaban in advanced renal impairment. Now, I discussed anticoagulation reversal in my previous transfusion medicine video, so you can refer to that. But for warfarin-associated life-threatening bleeding, the 4-factor prothrombin complex concentration, I'm going to call it 4-factor PCC, which contains factor 2, 7, 9, and 10 is first-line reversal solution. If not available, we can use the 3-factor PCC and the combination of 3-factor PCC and factor 7, as 3-factor PCC lacks factor 7. FFP is used when PCC solutions are not available. The goal in most cases is to drop the INR to equal or less than 1.5. Check INR level 15 to 30 minutes after completion of the infusion and repeat the infusion until INR is equal or less than 1.5, and if it's still elevated, we repeat the dose again. The patient's repeat INR dropped to 1.5 after the infusion. He underwent emergent evacuation, and the repeated CT head next morning showed post-operative findings without new bleeding. The next question is, when can we resume anticoagulation? In general, it's reasonable to consider restarting anticoagulation therapy 7 to 14 days after an episode of major bleeding, including intracranial bleeding. However, final clearance should always be obtained from the subspecialists managing the bleeding. For example, for intracranial bleeding, consult neurosurgery. For gastrointestinal bleeding, consult gastroenterology. This ensures that the decision to resume anticoagulation is tailored to the specific clinical scenario and the patient's condition. The patient was discharged to rehab 3 days later with instructions on when and how to resume anticoagulation. But 3 days later, you received a call from the rehab facility asking you to help with restarting anticoagulation in the same patients. And as we said, first I would call the neurosurgeon to get the final clearance to proceed with that. And given the patient is at high risk for thromboembolic disease, I will resume warfarin and bridge with low molecular weight heparin until the INR is therapeutic. Again, unfractionated heparin can be used, but it's usually reserved, as we said, for cases where low molecular weight heparin cannot be used. Let me take this opportunity here to quickly review reversal strategies for other anticoagulants. For direct oral anticoagulants, we follow the following reversal strategy. For dabigatran, as you know, idarucizumab is first line, or PCC solutions if idarucizumab is unavailable. If PCC is not available, then hemodialysis may be considered to remove the drug as the next step. Factor XA inhibitors, rivaroxaban, apixaban, induxaban, and andexanet alpha preferred as first line, or a PCC solution, and if andexanet solution is not available. Now, fresh frozen plasma has no role in direct oral anticoagulation reversal. Protamine sulfate is the primary agent to reverse the anticoagulation effect of unfractionated heparin and low molecular weight heparin in life-threatening bleeding. Let's move to the final scenario. A critically ill patient with multi-organ failure due to septic shock from severe pneumonia was being treated with vancomycin and cefepime.
The patient was also diagnosed with a right leg DVT and started on a heparin drip. On day 3, the patient developed bright red blood per rectum. A CBC revealed stable hemoglobin level, but the platelet count dropped to 32,000, down from a range of 80 to 90,000 over the previous 2 days. What would you do next?
Now, when there is significant bleeding, don't think twice. The first step is to immediately discontinue all kinds of anticoagulation, and the next step after that is to reverse the coagulopathy whenever appropriate. Now, in cases of minor bleeding episodes such as gum bleeding, minor epistaxis, bloody stool from inflammatory bowel disease, which usually not significant, microscopic hematuria, hemoptysis from lung abscess, hemoptysis from PU, of course, all these cases, we continue anticoagulations. So back to our patient, we discontinued heparin infusion, we typed and crossed 4 units of packed RBCs, we consulted gastroenterology, and we trended his hemoglobin or CBC. Now, whether to reverse the anticoagulation effect in our patient or not, this depends on the severity of the bleeding and associated condition. And in our patient, we avoided reversal given that he just had a fresh DVT and he has a stable hemoglobin. Now, what do we do about the critical thrombocytopenia? Should we transfuse with platelets or not? Again, this depends on the cause of the patient's thrombocytopenia. Is it DIC? Is it drug-induced? Is it heparin-induced? Is it sepsis-induced? So the coagulation parameters showed that the patient had elevated PTT and PT but normal fibrinogen, which means it's unlikely the DIC. But how about the heparin-induced thrombocytopenia? Again, we calculate the 4T score.
Let's calculate 4T score for this patient. So for thrombocytopenia, platelet count fall more than 50% and platelet nadir above 20,000, so 2 points. The platelet count fall less than 4 days without recent exposure, so I'll give him 0, because I don't think any of these 2 criteria here apply, so we'll pick 0. And thrombosis, I will pick none because this DVT present in admission. Again, I'm not aware if he received heparin before, but so I'll pick none. And other causes, to me, is definite because most likely his thrombocytopenia that early is related to septic shock. And again, also could be due to antibiotics when it dropped from 80 to 30. So it's low probability, less than 5%. So this patient is low probability of hit.
The 4T score is low probability, so that rule out hit. The patient's critical thrombocytopenia was likely, in this case, due to antibiotics or sepsis, and it's highly suspected due to vancomycin, which is known cause of thrombocytopenia. Now, vancomycin was stopped. Now, when thrombocytopenia is drug-induced, other than heparin-induced, of course, platelet transfusion is indicated in active bleeding to keep the platelet count above 50,000. So we gave the patient 1 unit of single donor platelets. Gastroenterology performed a colonoscopy and findings were consistent with ischemic colitis. The patient's rectal bleeding stopped the next day. So when do we resume anticoagulation? As we explained in the last scenario, anticoagulation can be usually resumed 7 to 14 days after a major bleeding episode. Gastroenterology in this case recommended waiting for a few days and see. And over the next few days, the platelet count improved to around 80,000. And day 5 after the bleeding episodes, the gastroenterology cleared the patient to resume unfractionated heparin infusion with close monitoring because he just had a fresh DVT and he's high risk for further DVTs. In critically ill patients and those at high rebleeding risk, I generally prefer unfractionated heparin infusion given its short duration of action. Low molecular weight heparin or direct oral anticoagulant can be considered when the patient becomes more stable and low bleeding risk. And speaking of which, when anticoagulation is required, a platelet count of equal or above 50,000 is considered safe, and a lower threshold of equal or above 30,000 can be considered if the benefits outweighs the risk of starting anticoagulation, like in heparin-induced thrombocytopenia. But where the IVC filter from all this discussion? The use of inferior vena cava filters is a topic of considerable debate in the medical community. IVC filters are indicated primarily for patients with venous thromboembolic disease who have an absolute contraindication to anticoagulation, or in those who have recurrent thrombosis or VTE disease despite adequate anticoagulation. This recommendation is supported by the American Society of Hematology and the American Society of Interventional Radiology. However, there are significant concerns regarding the routine use of IVC filter due to the associated risks and limited evidence of long-term benefits. Studies have shown that while IVC filters can reduce the incidence of PE in the short term, they are associated with increased risk of deep vein thrombosis and other complications such as filter migration, perforation, and thrombosis. The American Society of Hematology guidelines conditionally recommend against the use of IVC filters in patients who can be safely treated with anticoagulation therapy, citing low certainty in the evidence of their effects. And if we use filter, we should use temporary retrievable filter with removal once the patient can be safely anticoagulated. So back to our patient, we were able to resume anticoagulation within 5 days after the bleeding episodes. And I would only consider temporary IVC filter placement if the bleeding recurs after resuming anticoagulation in our patient. In the end, if you found this video useful, please give it a like, share it with your colleagues, and subscribe to the channel if you have not done so. If you would like to receive a summary of this video, kindly subscribe to my Substack page. The link is provided below. Thanks for watching and see you soon.